make that flip between sodium and potassium back in the cell, like we talked about at the beginning of the semester when we talked about the switch between sodium and potassium. It takes ATP energy for the sodium-potassium pump to work. How do I get ATP energy? I need glucose and I need oxygen. I can do it without glucose if I need to, because I can burn fat, I can burn muscle, but I can't do it without oxygen. So if I have a cell that is deprived of oxygen, just like we talked about with the MI, now I cannot repolarize, which is why we talked last week about the ST segment elevation that you start to see. First it's depression when we have lack of oxygen, and then if the oxygen doesn't come back and the cell starts to die, it can't repolarize and the ST segment is going to rise. So we've already learned that piece of it. Remember that every piece of the action potential is going to correlate to a certain piece of something going on in the heart. So as the SA node fires, we're getting ready, we're going to send that impulse, and that's where we're going to see this big straight up contraction that's getting ready to happen. So this is where the potassium is slowly coming out of the cell, and then calcium gets involved, and it stops it allows the slide to occur, and then this is the transition between the SA node and the AV that gets to once the AV contracts, it's an all or none down slide at that point in time. So pair up your action potential to what's going on in the heart, and then you know that the EKG beat is a direct representation of what's going on in the heart. So every piece of the EKG corresponds with the resting membrane potential for the action potential as well. So the P, which is going to be the firing of the SA node, lining up right here at baseline. Once it fires, it's going to go to the AV node, and that translation or that transmission is the PR interval. So that is the length of time it takes to go from the P to the R. You notice that the PR interval is lining directly up with this part of the action potential. This is where the sodium is passively going out, and then the potassium is going out, sodium is rushing into the cell. It is getting ready to be able to contract. And then the QRS, the contraction of the ventricle, is going to be represented by that slide down, the 1, 2, and 3. So here is where we see that the calcium is going to make its exchange, allow the slide to occur, and then it cannot do it again until we get to the repolarization, which is T, which is lining up with 3 and 4. Now, take your drugs and put them in there, because you have a slide that shows you the drugs that go along with all of those action, depolarization, repolarization cycles. So in the phase 1, again, sodium and calcium are moving slowly between the cell. In that's phase 0, that's the resting phase. Once the P fires, or the SA node fires, then we have the early repolarization starting in phase 1 where the sodium channels are going to close. Phase 2 is that plateau. That is where the calcium closed, or it was flowing in to allow the slide to occur. Potassium is being pushed out. Phase 3, which is the rapid repolarization, the calcium channels are going to close. Potassium is rapidly flowing out of the cell at that point. And then phase 4 is rest. Normal rest has to repolarize. I have to have oxygen to make ATP energy in order for that to occur. So this is the whole cycle. So just somewhere between these slides, put them together so you understand what's going on. All right. So I did give you this mnemonic. You've seen this mnemonic probably before in pharmacology. If you like pictures, this is putting it all together for you in picture with color. This is not a me slide whatsoever because I'm already lost on the pictures and the colors. But if you are a visual person, this one is a good one for you to see the action potential at the bottom, what is happening, and which drugs go with, along with the heart. All right, some other vocabulary for the basic EKG. When we talk about a cardiac cycle, I'm just talking about that 1 EKG beat. I already talked about depolarization, repolarization. The terminology for ectopic beats is just an extra beat. Paroxysmal means it starts and stops suddenly like an attack. Now, the EKG grid paper that I just gave you, this is measuring time on a horizontal line. So when you look at this, the main things to know about this paper is that there are little bitty squares and big squares on it. So the bigger square is the square that's probably the easiest for you to see, and that large square represents 0.2 seconds. You have to memorize it. Inside of each big square, there are actually little squares. So there are 5 little bitty squares inside of each big square, and each little bitty square measures 0.04 seconds. If I count 5 big boxes in a row, that equals 1 second. If I want a 6-second strip, how many big boxes in a row would I need to have? For 6 seconds. If 5 equals 1 second, I want 6 seconds. 30. So right now, on your grid, on your piece of paper, count out 30 blocks. Big box. So these are the boxes I'm referring to. You've got 5 little boxes inside. If you count out 30, in this instance, on this piece of paper, I have 15 counted, it's 3 seconds. 30 is gonna be 6 seconds. It's gonna help you be able to identify rate, heart rate, because remember, this is time. Now, there are some cheat grid lines on the bottom of the paper. So if you see these big lines that are coming down off the bottom, they're sticking down like this. They are showing you every 5. I'm gonna give you old paper and new paper. They are showing you the 30 on the grid on the paper I just gave you. So they are showing you. Wait, let me look again. They're showing you 15, 3 seconds. No, on your paper. Look at your lines on the bottom of your paper.
At the bottom, 30.
30. So they're showing you 30. So where each set of lines are, line in a line, it's a 6-second strip. What's the significance of 6? If I had 2 heartbeats in this 6 seconds, or I counted a pulse for 6 seconds and I counted 2. Well, you're trying to figure out the rate. So if I count something for 6 seconds, how can I figure out the rate? Times 10. So if I had 2, well, that's a bad example. If I had 6 EKG complexes inside of that 6 seconds, I could multiply it by 10 and get 60. And I could say, just by looking at this little piece of strip, oh, my heart rate's probably 60. Now that's not the most accurate way to figure out the heart rate, but it is one way that we can figure it out just by having a 6-second strip on this piece of paper. But I'm going to talk to you about other ways to figure out that's more precise. So if I am going to look at determining heart rate, what I really want you to do is to be able to determine rate by counting the number of large squares between an R wave, between 2 R waves, and then take the number and divide it by 300. So let's look at this piece of paper and say in this 6-second strip, I have 2 complexes right next to each other, and between the R waves, there's 2 big boxes. I'm telling you to take the number of seconds and divide it into 300. 2 big boxes between these R waves.
So 0.40 seconds apart. I know. She said 2. Oh, for 6. So that's 2 boxes.
Divide it the other way. It shouldn't be a point. I took 2 and divided it into 300. Okay. 150?
Divided by 300.
Okay, let's look at an example. This is what I was just trying to say, but instead of 2, I gave you in this example 5. There's 5 large boxes between these R waves. I took the 5, divided it into 300, I get a heart rate of 60. It's always the 300 if I'm using these big boxes to figure out heart rate. This is going to be a more accurate way. So if I told you I only had 2 boxes, which is my last example, so there was only 2, that would be a much faster heart rate. So when you just divided it, you came up with 100 and something. You did it by, I know what you did. Okay.
So right?
Yeah.
So
It was really high. Yeah. So rate calculation can be done in a couple different ways. The first way that we talked about was to count the number of our intervals in 6 seconds and times it by 10. Not the most accurate, you have to know that you have a 6-second strip, and that's fine. To be more accurate, we're gonna count the R waves, the big boxes between the R waves, and we're gonna divide it by 300. It's more accurate. To be the most accurate. You know, these little teeny weeny boxes inside of the big boxes. I can count all the little bitty boxes between the R waves, but then I have to divide it by 1,500. That's hard to remember.
Now, between the.
Yep.
Between every R, count all of those.
Just like this, to get the 6-second strip. If I know I have a 6-second strip, I am going to count every single R wave, and then I'm going to times it by 10. So here in the 6-second strip, I have 1, 2, 3, 4, 5, 6, 7 R waves that I can see. 7 times 10 gives me a rate of 70. Now, to look at these R waves and use the boxes, I have 1, 2, 3, 4 in a little bit. And then 1, 2, 3, 4 in a little bit. So I'm at really about 4.5 boxes between each R wave. So if I took 4.5 and divided it with the 300, what do you come up with? 66. It's a more accurate method of taking the rate.
But you need that 6, you gotta know that you have a 6-second strip.
You need to know it. So how do you figure out you have a 6-second strip? Well, you count your boxes. I have 30 boxes here in order to say I have the 6-second strip. So in this instance, you would have to identify your boxes or use your cheat sheet lines on the bottom of the grid in order to say it's a 6-second strip and what the rate is. This is why it's easier just to do it between the R to R, because all you need is a piece of strip this big, and you can figure out what the rate is. All right, so I gave you a piece of paper that looks like this, and it has some dysrhythmias on it. So the first one for A, tell me what the rate is.
That doesn't look like that. Oh. Is it 4 boxes? Mm.
I've got somebody saying 7, somebody saying 50.
Oh, this paper on there.
This should be the same paper, is it not?
No.
Oh, no. Surprise! Maybe I gave it, okay. So, up here, it's what? It's about 4.5 boxes in between each one, so 4.5 gave you about a 66. So on your paper, what did I give you on your paper? I gave you practice ones. About the same. I thought I gave the same strip, but it's about similar.
Yeah.
All right. So how about B? sounds good. Now, is that less than what would be considered a normal rate? What's a normal rate? 60 to 100. So since it's less than, this is bradycardia.
So you 300.
And then C?
It's 5.5. This one's 5.5.
Faster than 60. About 120. So it's greater than 100, it's tachycardia. Can we figure out a rate on the last one?
What they say.
What was that? The last one?
I just
Can you figure out the rate by the strip? It's irregular. The R to R's are not lining up regularly here. So, if I had a big pair of calipers, which I don't, that won't even fit. That won't even fit, but this one fits. So if the R to R's are not regular, I can't use this method. I need, just like if I was taking a pulse, to take it for the entire minute. So in this instance, is a tracing like this, just because I can't take the pulse or figure out the rate from this, does it make it abnormal? What kind of things can cause the heart rate to speed up and slow down like this? Is it normal for anybody? If this person was just laying down in the bed and you saw this, it's not AFib.
Sinus arrhythmia?
It is a sinus arrhythmia, but what causes sinus arrhythmia? We have this gradual lengthening and shortening of the R to R. What do I need to compare it with in order to say that this might be normal?
Can't it occur like in athletes?
Yes, it can occur in athletes and other patients who are, no? This is a perfectly normal person. Could be low weight, absolutely, young athletes, very well muscular. When you breathe, when you take in air into your lungs, does it squeeze the heart? Yeah. So the heart slows down a little bit, and then you exhale, and the heart can go a little faster. This happens in young people. It can happen with athletes. This is a sinus dysrhythmia, and it's normal finding, especially if you correlate it with respirations. All right, looking at interpretation, keyword. So in order to say that something is going to fall into sinus, we name our EKG rhythms based on which part of the heart is firing. So if our sinus node is firing and sets the pacemaker, we will always see a P wave. So in order to say that we are sinus, we have to see all the components and we have to be able to measure them, and they have to measure within their parameters. So when I look at the P wave, it is representing atrial contraction. I have to be able to see it to say that it's sinus, and it's going to be measured from the beginning to the end of the wave. The duration for a P wave should be 0.06 to 0.12. So it has to be less than 0.12. So I'm going to need to take a piece of paper or my card, which is your cheat sheet. And if you use a piece of paper and you have your P wave, I don't have one up on the board right now. Let me flip to here. I can take my piece of paper and make some marks where my P wave ends and stops. Then I can take that paper and go down to my grid lines. I know the timing of the little boxes. I just told you that every big box is how much time?
0.2.
0.2, right?
Mm-hmm.
wait a minute.
Yeah,
That was
0.2.
the little one, 0.2. So let's go back to that. But then these are did this.
The whole box is the same. The big box is the same. No, it's not. The big box?
This one,
That's what she's
right,
Oh, the
0.2.
big box is 1 second. What did I say? Wait a minute.
So now, if I knew, I just
Point
said
two,
that on
and
my
then each
P
little
wave
one
was
is
2
oh.
boxes.
Oh, point.
Cause I hold up my piece of paper now and it was the 2 boxes, that happened to be how long my P wave was, which is way too long, but just saying. I'm gonna take it and times it by the 0.2 and I come up with a 0.4 for the P wave length, which would be way too long, really abnormal, something wrong with that person at that point in time. If my P wave happened to be this big, what would that measure? 3 little
0.16.
boxes,
0.16.
3 little boxes,
0.12.
0.12.
Oh, 0.12.
How long did I say the P wave needs to be?
0.08 to 0.12.
0.06 to 0.12. So really, my P wave cannot measure any longer than 3 little boxes
I'm actually just practicing this because
to be
this stuff
considered normal.
Besides confusing. No, I know. I'm just gonna go get my binder.
Alright, some other things to think about with the P wave, the amplitude, it should not be any taller than 2 to 3 high. We're not gonna worry about that as much as we're gonna look at the shape. There should be no notching and no peaking in the P wave. The next thing we're gonna measure then is the next thing we're gonna look at is that after every P wave, there should be a QRS, because that's gonna be the ventricular contraction. So I'm gonna measure the QRS. The QRS should also not measure any bigger than 0.12, or half of the PR interval. Now, the amplitude of the QRS complex really doesn't matter, because what makes the difference is the lead that you're using. So it can be right side up, it can be upside down, it can be really big, it can be really tiny. That doesn't matter as much as how wide it is. Again, you should have all 3 components. You should have a Q wave, which typically deflects down. The R typically goes up, and then the S is gonna deflect back down. I'm gonna look at the overall shape, because there should be no peaking or notching in the Q wave, but I'm gonna talk about peaking or notching, because that's gonna represent things like bundle branch blocks. If my Q wave is too big, if it's bigger than, measuring bigger, then that could be a bundle branch block. From there, we're gonna look at the T wave. So in order to have a full contraction, I had to have the P, the QRS, the T. The T wave is repolarization. Now, there are measurements for things like the T wave, but that is more than you need to know, and that's stuff that you would be learning if you take cardiac classes once you graduate and get into ICU or IMCU or any ER, and they give you cardiac classes. That's where you're gonna learn the rest of these measurements. I only need you to know what you need to know for NCLEX. So looking at the overall, the entire beat should not be any more than 0.8 seconds for 1 heartbeat. I've already talked about the measurement of the P wave, and the P wave should be no greater than 0.12 when I'm measuring it. We are also going to measure the interval called the PR interval. That is the length of time for the conduction to get from the SA node to the AV node. The PR interval will never measure longer than 0.20. If it does, there is a block. I'm going to talk about blocks. This would be considered a 1st-degree heart block, anything measuring longer than 0.20. Then we measured the QRS. We said that is not going to measure any bigger than 0.12. We have already talked about the ST segment. The main thing we're going to look for in the ST segment is it's not depressed and it's not elevated. And then you have the T wave that has to be there. Now, there is another measurement that you have heard about many, many times, but you may not have put it together with this, and that's going to be the QT interval, measured from the Q to the end of the T. What is important about the QT interval? When do you hear about that? Prolonged QTs due to It is a delay, but what's typically causing it? What kind of things? Meds, it's meds. I heard somebody say
Yeah,
meds.
meds, some meds.
Some meds, there are tons, there's a whole list of meds that we have said, oh, well, it'll prolong the QT interval. Why is that something that's bad? What can happen if I prolong my QT interval and now this whole piece is getting longer and longer?
Winky block.
Not stopping oxygen.
Longer drop. Now you have a winky block.
Why though? And what kind? Something ventricular. So what's happening here is, you know that the heart has automaticity, it wants to beat. Well, if the pacemaker doesn't beat, the heart, another part of the heart thinks, oh, I should beat, right? If I prolong my QT, the heart is gonna think, or the rest of the heart is gonna think the pacemaker's not working, and it's gonna try and kick in and beat for the pacemaker. So if that happens, because my QT has gotten too big, it can put you into a sudden ventricular dysrhythmia, which could lead to VTAC, VFib, sudden cardiac death. So we have to watch that QT interval. That cannot get too long. Okay. So again, PR interval, I was just talking about this, that's the AV conduction time. It's measured at the beginning of the P to the QRS, and that duration should not be any longer than 0.2. It could be from between 0.12 to 2.2. Anything longer than 0.2 and it's a block. The next one is the ST segment. We just talked about that. You do not need to know the measurement of this. I just need you to watch to make sure that it is not ischemic, being inverted, or any type of cell death or blockage with the elevation, with like an MI. And then the QT interval, that's my repolarization time. It is measured from the QRS complex to the end of the T, and that duration should be less than 0.4. And there are a lot of meds where we're gonna be measuring that duration to make sure it doesn't extend past that 0.4. I've given you lots of pictures to look at with the breakdown of these measurements and of these segments, and this is something you absolutely have to memorize.
Is that U on here visible? Because I don't see it.
It's probably not visible. The U wave represents some different things. Not everybody has one. It is not necessarily always a normal beat. I'm not going to really talk about the U wave. It's nothing you need to know right now. Just that particular picture I have one. So when I'm looking at the EKG interpretation, besides focusing on the monitor, I need to know how the patient looks, because those monitors lie. They will look like somebody is in VTAC and be saying somebody's in VTAC, and they'll be sitting there and they're fine. They're not in VTAC. There's just a problem with the monitor. Same thing as if the monitor is alarming asystole, you probably don't want to run in and jump on somebody's chest, especially if they're sitting there eating breakfast. So overall, look at the patients, look at their heart rhythm. And now, when we're looking at the monitor strips, we're going to start with the evaluation of the R to R. We need to know, is it regular? If it's not regular, is it irregular? Is it irregularly irregular? Is there a pattern of any kind? First thing we look for is there a P wave. Are all the P's present in front of every single P? And are they followed by a QRS? Are all the P's the same shape? Are all the QRS's the same shape? In a regular sinus rhythm, we're going to have a P wave followed by a QRS, followed by a T, and they will all measure within the guidelines I just gave you. That makes it sinus. Does that make sense? You need to practice that. So measure the length of the P, less than 0.12. Now, odd looking P waves. If I have peak notched or enlarged P waves, some things this could mean are things like atrial hypertrophy. If my P wave is inverted or slightly retrograde or measuring too short, this is in a reversed electrical conduction, meaning that the P wave is not firing. This impulse is being generated from the AV node, and it is being retrograded or pushed back up to the atrium from the AV node. So any P wave that is measuring less than 0.06, and it looks like it's smashed right on next to the QRS complex, that is actually fire from the AV node. Varying P waves means that they don't all look the same, or they don't all measure the same. This is a wandering pacemaker. It can be coming from all different parts of the atria. We just don't know which part is going to fire, and it's probably not the SA node. We have a totally absent P wave. The conduction is coming by some other route other than the SA node. Usually if it's absent, we are conducting from the AB node or somewhere in the junctional area. So just giving you some pictures of this. A bifurcated P wave usually signifies left atrial enlargement versus a very tall peaked P wave, or a tall P wave is right atrial enlargement. Measuring that length of the PR interval, that's the time it takes for the SA node to get to the AB node. Again, 0.12 to 0.20 being the biggest. Anything greater than 0.20 is first degree heart block. And that's a conduction delay between the SA node to the AB node. If my PR interval is too short, this is saying that it originated from somewhere else other than the AB, or other than the SA node. So again, we need to know the full length. Is it too short? Is it too big? QRS, duration should be no bigger than 0.12. Again, we're gonna look at the shape, and we need to note, do they all look the same? If there is no P wave in front of the QRS, again, this is probably coming from somewhere else in the AB ventricular system. Q waves. We talked about a Q wave when we did MI. If I have a very deep Q that is measuring down more than 0.2 millimeters, or it's 25% of the R wave, then that is a Q wave, and that signifies that somebody has had an infarction previously, even if they didn't know about it. So here's where we pick up on some silent MIs, because somebody comes in, has an EKG, they shows a Q wave, and we say, well, you had a heart attack, do you ever know? Did you remember having one? And then I talked about the measurement of the QRS complex being too big or being abnormally shaped, and these are bundle branch blocks. So that means that when the impulse travels down the right and the left bundle branch, one of them could be blocked, which can delay the conduction time. If I delay the conduction time on one side, my QRS is gonna widen past that 0.12, and if I see bunny ears, just like that one is there, that is characteristic of a left bundle branch block. So what happens is the right side depolarizes first, and then the left side depolarizes, which gives you the bunny ears. So that, and normally wide one without bunny ears, that's a right bundle branch block, but the bunny ears are always a left. Bunny branch block, yep, left. And any kind of enlargement of that QRS besides the bundle branch block can also signal hypertrophy of the ventricles. So that's another thing to keep in mind. ST segment, we've talked a lot about. T waves, some things to look at that. Is it a normal, flat, or peaked? A notch or a pointed T wave in an adult can signal something like pericarditis. And then you know that changes in potassium can also be seen on the EKG. If I have hypokalemia, it could lead to things like depressed ST. A flat T wave, here is where that U wave comes in, because if you see a U wave very prominent on the EKG, that could signal hypokalemia is occurring. And then that prolonged QT interval that you were talking about, but I was getting at meds instead of potassium. And then hyperkalemia, you see tall peak T waves, prolonged PR intervals, and loss of the P wave altogether can be hyperkalemia. These were the changes due to an infarct, and then this is what hyperkalemia can look like on a T wave, and this is what hypokalemia can look like on a T wave. The last thing we talked about was that QT interval. So again, the QT interval should be greater, the length should be between 0.50, duration should be less than 0.04 seconds. If I am getting past 0.50 on a QT interval, this will significantly increase the risk of that ventricular dysrhythmia occurring and causing death. So if I am on a medication that they know will prolong the PR interval or the QT interval, one of them that we see frequently used in the IMCU is Dickinson. So Dickinson therapy, which is gonna be used for atrial fibrillation, we'll talk about it later, prolongs the QT interval, and they have to do serial EKGs before and after giving this medication to watch that, because they can't give the next dose if the QT interval is too long at that point. Now, other things that change the QT interval, if my heart rate is going to be decreased, it is going to increase the QT interval time. So a decrease, or an elevation in heart rate can decrease the QT, and a decrease in heart rate can increase the QT, making it longer, prolonging it. And that's just showing you a long QT. This is a whole list of drugs that can potentially cause that lengthening of the QT interval. And then that U wave that could potentially follow at the end, again, could be prominent, most likely during hypokalemia, also hypercalcemia or digitoxicity can show a U wave. The other thing to think about when I'm looking at that stress, is there any other ectopic beats that are coming early? So that goes into, is it regular or irregular or regularly irregular? If there are ectopic beats, we have to figure out what they are and where they're coming from. If I'm gonna name a rhythm, the rhythm names from its origin of where it's beating from. So if the sinus node is beating, it's a sinus rhythm. If the AV node is beating, it is going to be a junctional rhythm or an atrioventricular rhythm. If only the ventricles are beating, it's a ventricular rhythm. So when you hear the term ventricular fibrillation or ventricular tachycardia, that's because the beat is originating from the ventricles. If you hear sinus brady, sinus rhythm, sinus tach, the beat is originating from the SA node. When I name the rhythm, I start with where it's beating from, and I'm gonna go to the rate. So sinus bradycardia, ventricular tachycardia, that's how the name goes. And then I put in any type of abnormal beats after, that's at the end. So for instance, if I have sinus rhythm with PVCs, which are premature ventricular contractions, that ectopic beat goes at the end. So that is the rule for naming rhythms when I look at my cardiac rhythms. So in order to say I have a normal sinus rhythm, I have to check, are the R to R's regular? Is it a normal rate between 60 and 100? Do I have a P wave for every QRS complex? Are all the P waves measuring correctly and are all similar in size and shape? Are all the impulses conducted to the ventricle? Does the ventricle measure correctly? Do I have a normal PR? QRS complexes all have to look the same and be less than 0.12. Normal QT interval. Everything normal about the T wave, upright, round position. No ectopic beats. If I can meet all this criteria, I have normal sinus rhythm. This is as far as I want to go. I just need you to know normal up to this point so that we can then start talking about what makes it abnormal. Does it look tacky to you?